René Descartes published a book called Treatise of Man in 1664. In it, he described pain using an image that would govern medical thinking for nearly 300 years. He asked the reader to imagine a boy with his foot too close to a fire. The heat pulls a delicate thread running from the foot up the leg and into the brain, where a tidal door opens to let the pain through. An image so mechanically self-evident that it lodged itself into the foundations of Western medicine and stayed there for 300 years. A linear progression. You hurt yourself, the body sends signal to the brain receives it. And the result is that you feel pain. The problem is that it describes only a small and misleading portion of what pain actually is, and there were always so many examples that baffled the scientists and the doctors that nobody could settle in the final definition. Soldiers in battle have reported completing entire engagement without noticing wounds that should have been incapacitating. Patients who have had limbs amputated continue to feel pain in the limb that no longer exists. People with identical injuries experience wildly different levels of pain, and people in chronic pain sometimes have no detectable tissue damage at all. The Cartesian model explains none of this, and the story of pain goes much further back than Descartes. What you find when you follow it all the way is that the question of what pain is has always been inseparable from the question of what pain means. Homer used at least 4 different words for pain in the Iliad and the Odyssey, each one pointing at a different aspect of the experience. Algos named the raw sensory fact of physical pain. Ponos named the painful labor of sustained effort. Odin named the more acute, penetrating kind that pierces. Ache named what settles in chronically, grew worn into the body over time. The Greek who produced these words were describing something they observed about how radically different the pain of a spear wound is from the pain of years spent far from home, even if both can be equally crippling. Pain in this framework was evaluative. It carried information about value and threat, about what the body needed to move away from. For the Stoics, pain was a judgment as much as a sensation. The body may suffer, but the rational mind can decide whether to engage with the suffering or not. For them, the meaning of pain is not contained in the pain itself, but in how the person relates to it. This position was very pragmatic because pain, in this understanding, was the instrument of practice. The capacity to endure pain without being mastered by it was a discipline, cultivated through repetition the same way the body is cultivated through training. Christianity absorbed this idea and transformed it. It became considerably more loaded. The logic of Christian suffering runs directly from the specific, documented suffering of Christ's body as the mechanism of redemption. Pain, in this framework, could be offered upward. It had value precisely because it cost something, that participated in the cosmic economy of suffering and salvation. St. Paul wrote that he rejoiced in his sufferings, completing what was lacking in the suffering of Christ. What he was saying is that physical pain could be a form of participation in the divine. From this theological foundation, Christian practice developed the elaborate tradition of mortification of the flesh, the deliberate infliction of physical discomfort as spiritual discipline. The technology for it were tools for subduing the body's appetites and building the soul's capacity to resist temptation, for accumulating merit that could be offered on behalf of others. St. Dominic Loricatus wore an iron breastplate against his skin and flagellated himself so intensely and for so long that contemporaries calculated he had, over the course of his life, performed the equivalent penance of several human lifetimes. And this was recorded not as a horror story but as an achievement. The body was the site of struggle, and pain was the evidence that it was being taken seriously. The medieval body in pain was a body in relationship with God, embedded in a cosmic structure of sin and redemption, connecting through its suffering to the community of believers. Pain had a meaningful place in the structure that could not be replaced with anything else. The Enlightenment produced a different ontology of the body, a different account of what the body is and what happens inside of it. The mechanical model of Descartes was part of a larger project of separating the body from the soul, the physical from what cannot be measured. The body became a machine and pain became a signal in this machine, and signals in machines are problems to be corrected and eliminated. This was a genuine and important liberation in some respects, even though it created problems in others. The conviction that pain was punishment from God, or the price of spiritual inadequacy, or something that should be endured rather than treated, had caused immeasurable suffering that medicine gradually learned to alleviate. The development of anesthesia in the 1840s, when ether and chloroform used in surgery for the first time, produced a cultural shock that is hard to overstate. Patients had previously been held down and operated on fully conscious. So, to many who witnessed the early procedures, the new technology felt like a miracle. The surgeon Robert Liston, who performed the first operation under ether in Britain in December of 1846, turned to the audience of observers afterwards and said, "This Yankee dodge beats mesmerism hollow." But the mechanistic model, even as it enabled analgesics and anesthesia and surgical advances that genuinely reduce human suffering, also created a new blind spot. By treating pain as a direct transmission from damage to brain, it created no framework for explaining the enormous variation in pain experience between individuals, the role of attention and expectation, the ways in which the same tissue damage produces completely different pain depending on who the person is and what the pain means to them. Henry Beecher, an American anesthesiologist who served in the Second World War on the Italian front, noticed that severely wounded soldiers, men with injuries that would have sent a civilian screaming, frequently reported little or no pain and declined pain medication. The same wounds in civilian patients were accompanied by severe pain and strong requests for relief, and the reason for that difference was not easy to explain. Beecher eventually published a paper in 1946 arguing that the meaning of the wound was central here. For the soldier, a serious wound was accompanied by a sense of duty, of him fulfilling an honorable task of protecting his country. For the civilian, the same injury meant disruption and loss, and intrusion into a life they expected to continue and bother. The framework provided completely different experience when the damage was exactly the same. But it took a couple of decades until a paper that finally broke the Cartesian model was published in Science in November of 1965. Ronald Melzack and Patrick Wall, working at MIT, proposed what they called the gate control theory of pain. The core of the argument was that the spinal cord contains a mechanism, a form of a gate, that regulates how much pain signal gets through the brain. That gate is not a passive channel, it is actively controlled by multiple inputs, by the signals coming from damaged tissue, but also by signals coming down from the brain itself, by the person's emotional states, their level of attention, and prior experience of similar pain, by what the situation means to them. The gate can be opened or closed by any of these factors. Nervous system produces pain after integrating all of them, so it is the output of the whole system rather than a raw signal arriving from the site of damage. Melzack later extended his model into what he called the neuromatrix theory, the idea that the brain contains a body self-map, a distributed network that generates the experience of having a body. Pain originates in this network and not in the site of damage. If the body operates by a map, the pain is generated in a region regardless of whether the physical limb is present, because the map itself has been disturbed. The implications of the theory were profound and are still being absorbed by medicine. If pain is produced by the brain rather than the simply received from the body, then attention, expectation, belief, memory, and meaning are not peripheral to pain. They are constitutive of it. Changing what a pain means to a person changes the experience of it. A good example of it is the placebo effect, which works on pain because the expectation of relief actually changes what the brain produces. Multiple studies show how identical injuries heal at different rates in different emotional contexts, and the color of a pill affects how much pain relief it provides, because the brain's prediction system assigns different weights to different stimuli. This puts all our previous heroes in new light. The Stoic philosopher who trained himself to endure pain without being mastered by it was changing his relationship to pain's meaning, and by doing so, changing what the pain produced in his nervous system. The medieval monk who wore a hair short was not hallucinating when he reported that the discomfort lessened over time through prayer and intention. The brain's predictive machinery was being trained to assign a different value to those sensations, and the system was responding accordingly. The same happens to the elite athlete who regularly pushes through training pain and develops what sports scientists call pain tolerance. It is, in neurological terms, very similar. Repeated experience of a specific kind of pain understood within a specific frame of purpose genuinely changes how the nervous system processes it. This is documented, measurable, and consistent across research. Athletes who have trained through years of competitive sports have measurably different pain thresholds and ceilings than sedentary people. And the difference appears to be not just psychological in the dismissive sense that the term is sometimes used, but neurological. The brain has reorganized itself in response to sustained exposure, thus the experience changes. Yes, the monk and the marathon runner operate on different theories, aim at different ends, and would not recognize their kinship. But both have discovered that the relationship between pain and the person experiencing it can be transformed not by denying the pain, but by changing what it means. This is the notion that Descartes would not contend with. The Stoic, the Christian, and the sports scientists all agree today that meaning changes the experience of pain. Where they diverge is on where this meaning comes from. The Stoic holds it as a byproduct of rational judgment, something imposed on experience through philosophical discipline. The Christian receives it as a given because suffering participates in a cosmic structure that exists regardless of what any person thinks about it. The sports scientist understands it as something the nervous system constructs from context and repetition, neither imposed nor given, but accumulated. These are not small differences. They describe entirely different relationship between the person and the pain, and the physical outcomes are well documented in all three cases. The nervous system does not especially care which theory you hold, but it definitely responds to the change in the relationship. What Descartes did get right, underneath the inadequate mechanical model, was the intuition that pain is a perception rather than just a sensation, that exists in the brain and not only in the damaged tissue. The address was correct even if the understanding of what lived there was not. The question this leaves open is whether meaning is something the brain assigns to pain or something that pain in certain conditions carries intrinsically.